All right, welcome back, everyone. My name is Etienne Breton. I'm a research scientist here at IPUMS, and I'm excited to chair this second set of oral sessions on data linkages and health trajectories. We have presenters here from different fields: economics, sociology, data science, some in person, some online. So I will just be presenting them in order and then keeping time for the presenters to make sure we stay on track with our time commitments. First will be, and I'm sorry again for any mispronunciation of names, Muzhe Zhang, who is a professor of economics in the College of Business at Lehigh University. His research examines how environmental, workplace, and policy factors affect vulnerable populations, particularly pregnant women and infants. He also studies a broad range of policy-relevant topics, including physician prescribing behavior, provider quality reporting, food advertising, paid family leave, and the health consequences of disruption to circadian rhythms. So a wide breadth of topics. Afterward will be Katie Spoon, who is a postdoctoral data science fellow in the Stanford Institute for Human-Centered AI and a New Map of Life fellow in the Stanford Center on Longevity, where she develops interpretable, scalable methods for representing and analyzing trajectories as an alternative black box model focused on predictions. Afterward will be Sinyee Liu, who is a PhD candidate in sociology at the University of Illinois Urbana-Champaign. Her research examines the future of work, labor market inequality, and population health, with a particular focus on work hour instability, remote working, and workers' health and well-being. And last but not least will be Zhang, who is a doctoral candidate in sociology at UNC Chapel Hill and a pre-doctoral trainee at the Carolina Population Center, where her research examines the causal pathways underlying social disparities in population health and aging. So without further ado, let us begin the session. Thank you.
Okay, good morning, everyone. Thank you for giving me this opportunity to present this research. I am Muzhe Yang from Lehigh University. My flight yesterday was canceled, so hopefully I can come to this conference tomorrow in person. My study looks like the long-term impact of a pandemic, in particular, the 1918 flu, which happened more than 100 years ago and provides a rare opportunity to study such an impact of early life shock. Existing studies have already examined, existing studies have linked prenatal exposure to the 1918 flu with adverse outcomes in education, health, and earnings from childhood to adulthood. My study extends that literature by focusing on old age mortality, given that longevity captures the ultimate long-run health consequence, and it is also a key indicator of social welfare. For old age definition, my study uses 65 as the cutoff, following the guide by the National Institute on Aging. As the case for most empirical studies, identification is the key challenge. In this regard, a seminal work by Almond treats the full wave of the 1918 flu as an exhaustion shock and compares the 1919 birth cohort with adjacent cohort. Here, one important confounder is World War I, which coincided with the pandemic. A follow-up study by Beach et al. Provides evidence pointing out that the 1919 birth cohort is actually negatively selected on parental socioeconomic status. To solve this problem, both studies here also emphasize the usefulness of geographic variation in pandemic intensity. Specifically, Beach et al. Provide evidence that city-level excess influenza mortality is plausibly exogenous and construct a measure that captures the unexpected 1918 spike relative to each city's pre-1918 trend. So what I did in my study is addressing selection into birth cohort by conditioning on an extensive set of background characteristics, and also by using this unique measure constructed by Beach et al. 2022. I use this measure to classify cities into the low and high intensity groups. And I focus specifically on low pandemic intensity. First, I want to clarify that this focus does not mean assuming small shock. Compared with high intensity, low intensity places may not induce stronger private protective behaviors. So prenatal exposure to adverse conditions could translate more directly into fetal damage. And low intensity could also be the result of stronger institutional responses. And these interventions may increase stress, causing disruption during pregnancy. As previous study shows, maternal stress during pregnancy can negatively affect a wide range of offspring outcomes. The empirical study here of my uses scarring versus selection framework. So scarring refers to lasting damage of in utero exposure to adverse conditions among survivors. Selection, or called culling, happens when a severe shock increases fetal loss or infant mortality, leaving a survivor cohort that has better health. It is this low intensity setting that has received relatively limited attention in prior work, and my study aims to fill this gap. Now, regarding mechanisms, maternal stress during pregnancy can be viewed as upstream sources of fetal scarring, while later adult socioeconomic outcomes can be viewed as downstream pathways through which early life damage may translate into shorter longevity. The data sets of my study use the following sources. One, here, 1, 2, 3, 4, 5. The first one is the unique measure prepared by Beach et al. I got their dataset from their replication package on the journal website. The second one is the 1940 census linked to the Social Security Administration death master file, often referred to as census DMF. Number 3 and number 4, number 5 are from IPUMS, the 1920 full count census, together with the 1920 to 40 and 40 to 50 linked censuses to track education, job quality, and wages into adulthood for the same individual. Here, I want to point out that census DMF provides exact birth year and months, and this allows me to do these exact comparisons of the 1919 and 1918 birth cohort, plus using the birth month fixed effect to control for seasonality in birth outcomes. Here's a preview of my findings. In low-intensity cities, males born in 1919 live about 3 months less than those born in 1918, which is an effect comparable in magnitude to the long-term longevity impact of losing 1 year of schooling found in prior literature. In high-intensity cities, estimated mortality effects are smaller and statistically insignificant, which is consistent with selection potentially masking scarring and making the net effect harder to detect. Results are also robust and have passed a series of validity checks, which I will only briefly mention in this presentation because of the time constraint. Furthermore, mechanism analysis suggests a possible downstream labor market pathway. Exposed males born in low-intensity cities entered lower status occupations and experienced persistently lower wages, consistent with prenatal scarring translating into later life socioeconomic disadvantage. Methodologically, my study also shows how to use causal machine learning, specifically generalized random forest and double DBS ML, to uncover treatment effect heterogeneity where subsample analysis is not feasible because of the small cells. Results indicate that parental education could potentially be an important moderator of the longevity impact. Finally, I want to say that the focus on males is due to data limitation. Nevertheless, it is still a very important population given that male fetuses may be particularly vulnerable to prenatal shocks according to the so-called fragile male hypothesis. Now, here I will just briefly describe 3 features of the 1918 pandemic in the US that are relevant to our identification strategy. First, it unfolded in multiple waves, with the full 1918 wave being the most fatal one. this timing means that many 1919 births, especially early births, were in utero during the fall peak. Second, the pandemic severity varied significantly across cities, in part because cities responded differently and also in ways that didn't track a city's long-run economic trajectory. And this means that idiosyncratic policy variation could have translated into unexpected differences in influenza deaths. Third point here, the pandemic coincided with World War I, triggering selection problem. This means that we must address selection and confounding in adjacent cohort comparisons. So my corresponding identification strategy relies on the following: 1, 2, 3. The first one is using this within city adjacent cohort comparison, 1919 versus 1918 birth cohort together with the birth city fixed effect. Number 2 is using this unique measure provided by Beach et al. 2022. Number 3 is controlling for a large set of covariates, which have also been used in previous studies such as Beach et al., including race, birthplace, parental birthplace, birth order, father's occupation, mother's labor market participation, parental age, parental education, home ownership, and birth month fixed effect. The validity of this identification strategy is supported by this finding, which is conditioning on city level excess influenza deaths. Background characteristics appear balanced between the treated and control groups, and the estimated treatment effects are also robust to controlling for background covariates, city, and birth month fixed effect. Now, you may think about life course major event. Yes, so the two cohorts actually live through a lot of events, including Great Depression, World War II, Medicare introduction in 1965. Those could be viewed as common shocks to both groups since they are only 1 year apart. And this is supported by the falsification test, which I did in this paper using adjacent cohort comparisons. In the next few slides, I will quickly show the cities included in the estimation sample by intensity selection problem found by the previous literature and the balancing check result. This is the map showing the cities including in the sample used for estimation. At that time, there were no Alaska and Hawaii, so only the lower 48 states here are on this map. And then the next map showing the two groups of cities, low versus high intensity groups. Overall, the figure shows that the low and high intensity cities often coexist within the same broad area. The spatial pattern appears to be consistent with this plausibly exhaustion variation in the unexpected 1918 severity across cities. And this is the map, this is the figure I replicated with this consistent with the prior study found that this SES deficit represented by education could be purely explained by lower SES of the parents, especially fathers. And this is the balancing check result, which I found that most of the characteristics are balanced once by conditioning on this excess mortality death measure constructed by Beach et al. Study. And then the model for the estimation is here. I realized this is being recorded, so if you are interested in a little more technical detail, you can always come back to this part of the recording, and then you can take a pause and then go over the details at your own pace. This is the figure showing the main findings of this paper. So here are the main results. Number 1, the 1919 versus 1918 comparison shows that the scarring is detectable even when pandemic severity was low. And other adjacent cohort comparisons show basically 0 effect. And the mortality impact estimates in high intensity cities are noisy, suggesting that selection or calling could potentially mask scarring when the shock is severe. Now, let me also quickly jump the results by parity and birth quarter. These results are largely consistent with the prior literature, so I will just jump these details, which you can come back to the recording at a future time. And robustness checks also explained on these slides here. alternative specifications. Now, this is the result I will just briefly mention regarding the potential labor market pathway. So here, my study explored the potential pathways through labor market outcome, which can be viewed as downstream of maternal stress during pregnancy, which is triggered by the pandemic. So here, for the education outcome, these results are largely consistent with the prior literature, which found that the results are kind of mixed. But once I split into the low versus high based on the excess mortality deaths, the results seem to be concentrated in the high intensity areas. And the impact also negative here for employment, likelihood, and impact are particularly salient for the low intensity group compared with the high intensity group. And also wages here from 1940 and also in the 1950 census. So wages in 1940 were lower, but the wages in 1950 were higher in the high intensity group, but this seemed to be persistent, especially for the low intensity group, suggesting this potential labor market pathway, especially for males born into the low intensity groups. So overall, this table suggests this pathway where fetal scarring could push those born in low intensity cities into lower status early jobs, depressing earnings persistently, and also potentially ultimately lowering longevity. Now, given that my time is basically used up, I will just mention one message I want to emphasize at the very end of my study. So one important policy implication is that even modest severity settings could potentially generate long-term fetal harm, potentially through stress and other socioeconomic channels. So this emphasizes the importance of policies that protect and support vulnerable populations groups such as pregnant women during outbreaks, not only in the hardest hit places. And that's all for my presentation. Thank you very much for your time and attention.
I'm a postdoc in data science at Stanford, and I'm excited to share preliminary work on representing health trajectories and identifying where they diverge. So let's say we take two 55-year-old women who were diagnosed with diabetes at the same time. We can then see each of their health trajectories over the next few years, and we might see that one of them has worse outcomes, whereas another one has better outcomes. And we're interested in if there are diagnoses that persistently redirect a patient's trajectory to one with better outcomes. So this idea of turning points has been theorized in life course sociology literature, but has been hard to operationalize. But I think a very important question for intervention to know, are there certain diagnoses, that are turning points or critical events or tipping points? There's a lot of different phrases, but that's the idea. A lot of prior work on health trajectories uses European registry data. In the US, prior work often focuses on hospital data, so inpatient records. Those are often from a single care system or for a single disease. And the vast majority of work focuses on predicting outcomes, so who's gonna have a worse outcome, without understanding where, in the trajectories, two patients' paths are separating. And I think primary care is a uniquely rich place to look for answers to this question, because this is the setting where divergence in trajectories is likely most visible. You have patients coming to see their doctors over multiple years, and I think crucially, they're there before they become, very sick. Whereas with hospital data, people are typically admitted once they're, already pretty sick. We're using data from the American Family Cohort on about 8 million patients at over 1,000 clinics in the US. And we have their diagnoses, prescriptions, lab results, and full text visit notes. I'm going to focus on diagnoses for now, but we're planning to incorporate the other information. And we're using a network, which is a way of representing complex data that maps how diseases cluster and progress together. And what I like about this is it lets the strongest relationships emerge. Rather than saying, okay, we want to study diabetes, and because we assume diabetes is the most important, we can say, okay, let's look at diabetes in the context of all the other diseases and actually see which ones come out. So it's a more inductive way of looking at this. So I have two questions that I want to talk about today. The first is just what is the disease trajectory landscape look like in US primary care? It's been a little bit hard to get like a full answer on that just because of the lack of data. And then at the end, I'll talk a little bit about how we might be able to operationalize turning points in that disease trajectory landscape. So for the first question, we need to first build a network. So we take sequences of diagnoses over 5 years. So each person has their sequence over time, and then basically we create network snapshots at each 6-month increment. So for example, this part of the sequences become this first snapshot of the first 6 months, and basically an edge between two diseases, or the gray nodes, means that that pair of diseases co-occurs at a greater rate than expected in the population. So basically we're turning this individual level sequences into a population aggregate. And then we do that for the next 6 months and the next 6 months, and then we get all these snapshots that represent disease relationships in the population. The nice thing about using a network is then we have access to a bunch of statistics from network science that tell us things about the network, like centrality measures. One of them that I think is interesting here is betweenness centrality. So a disease with high betweenness centrality means that that disease is a bridge between many other diseases in the network. And so when we aggregate edges across time, two types of disease clusters emerge. Some of them are chronic disease clusters. These are things like cardiometabolic conditions, neurodegenerative, mental health. And I've highlighted the diseases within each cluster that have the highest betweenness centrality. These are things like sleep disorders, obesity, and fatigue. So those are nodes that connect a lot of other diseases. On the other hand, we also have disease clusters that are more episodic. These bring people to primary care more sporadically, tend to be less severe than the chronic conditions. These are things like musculoskeletal, skin and dermatology, and digestive conditions. And again, I've highlighted the ones with the highest betweenness centrality. So while I highlighted, the most central nodes within each cluster, it's actually a relatively small set of diseases that serve as bridge nodes, and they tend to be prevalent, but not necessarily. So here is patient prevalence, so the number of people who have the condition on the x-axis, and then betweenness on the y-axis. And while, for example, hypertension is the most common condition, it's not the one with the highest betweenness centrality. Those actually tend to be episodic. So GERD, soft tissue disorders, and back pain being the top kind of bridge nodes in the network. So I think this is interesting because these undirected co-occurrence edges tell us which diseases cluster together, like which are diagnosed in similar points in time, or which are comorbid. But the order the diseases were diagnosed matters too, and that's like where the idea of a trajectory comes in. So for that, we need to add another edge to the network, another type of edge, which are directed edges. And so here, an arrow between edges means that the earlier diagnosis predicts the later one. That's what these orange nodes are, again, in the population as a whole. So it's not that a single person has one disease and then they get another one. So this lets us see which diseases are upstream on average versus downstream. So I'm going to put all of the disease clusters on both sides, both as sources as well as targets. So when we do this, we can see these, this like top half tend to be net sources, meaning that they predict more diseases upstream than they are predicted downstream. And the top one is actually musculoskeletal conditions. So this means like on average in the population, these are much more upstream and they tend to be first. So this is what brings people to primary care. On the other hand, these disease clusters at the bottom are net sinks, meaning they are more often predicted downstream. Neurodegenerative conditions make sense as it's they tend to be more severe. But there is like, yeah, a lot of interesting variation. So these types of questions tell us which diseases connect the landscape and how chronic disease progresses, but it doesn't tell us why the two women we started with end up in different places. And that's the part that we, have been a little bit, this is very preliminary, but basically trying to move from the population level to the individual level. And you can't really do a causal analysis with a network. So this isn't causal, it's like quasi-causal. But we have a counterfactual design where we take everybody in an index cohort, for example, everyone who's diagnosed with type 2 diabetes, match them on a bunch of things, and then basically see, okay, for people who, had another condition that they acquired, can we compare the downstream disease networks of those who acquired it versus not, and ask, does acquiring this condition reorganize the downstream disease landscape, and by how much? So like if they don't look different at all versus if there's a very big gap and suddenly there's a lot more relationships that have been changed. When we compute this for all diseases and see which reorganize the downstream disease networks the most, that turns out to be bipolar disorder, mechanical complication, cluster headaches, and ovarian dysfunction. And I think it's really interesting. This is a schematic of some preliminary results. When we split by age, the results are very different. So looking again at the gap between people who, in the networks, between people who acquired or did not acquire this disease, colon cancer in early adulthood is the one that comes out as the most reorganizing or most disruptive. So we could maybe call this a turning point. But in midlife, the gap reduces, and then in older adulthood, it's basically no difference. Similarly, Alzheimer's is very disruptive in midlife and a lot less so in older adulthood, even though it's much more common in older adulthood. And then versus something like the fracture of femur, which has no gap in early adulthood or midlife, but is very disruptive in older adulthood. So I think this is, represents a possible way of identifying these diseases that might function as turning points at different ages. So as a summary, US primary care has, a distinct disease trajectory landscape with chronic and episodic clusters. And in primary care, we are able to see a lot more of those episodic diseases that come up. We can see identifiable bridge nodes between those clusters. Specifically, musculoskeletal conditions are upstream, so treating them earlier may be important. And while bridge nodes are interesting because they connect a lot of different diseases. They're very different from the idea of a turning point, which has to have like a trajectory redirecting effect. We are hoping that some kind of counterfactual design can detect conditions that persistently redirect the downstream disease landscape, which seem to vary by age. A lot more validation is needed to see if this method can help generate new hypotheses about disease relationships and intervention points. We are starting to work with a primary care physician right now to help make sense of these, but I would appreciate any thoughts if you have them. My email is here. So thank you.
Hi everyone. Thank you so much for the organizer for organizing such a big big data network conference. And before I begin, I'd like to quickly share updates that this paper, co-authored with my advisor, Dr. Tim Liao, is available online. So if you're interested in reading more the technical details, you're more than welcome to click on the link here by the Journal of SSM Population Health, and you will be able to see more details here. And for today's presentation, I'd like to talk more about the data linkage and the research design decisions here, because this is a data conference. So with that, the presentation today and the paper is titled Unstable Hours, Unequal Health, the Gendered Occupational Health Costs of Work Hour Volatility in the United States. And I am Sinyee Liu, a PhD candidate from the University of Illinois at Urbana-Champaign. I am a sociologist by training, so I would just talk very briefly here about how sociologists of health will this problem of work hour association with health. So several motivations here. First, the precarious work have been increasingly recognized as an important determinants or social economic factors that influence health outcomes. But we know relatively little specifically about work hour instability and its association with health consequences. And second, the gender might shape those health consequences, because gender have been influencing both the exposure to health risk and also the workers' responses to health strain. But still, we know little about in this specific context of work hour instability. And third, conventional approach usually use the employee-only sample, and this approach might underestimate the harm, because workers, they might reduce or quit jobs completely if their health problems are so severe. So this problem actually call for some specific research design that can make this selection bias more visible, if not being able to fully address the problem. So therefore, this paper here tried to answer the following question: how does unstable work time become visible as a health risk here? And to answer this question, I will actually talk more about how we utilize the data, because I think we are here to learn more about how IPUMS help us as a researcher to make those research possible. So this paper utilized the current population survey collected by U.S. Census Bureau and harmonized by the IPUMS big data network. So the CPS itself provides the monthly basic files. It collects every month repeatedly throughout the years and for several decades already. And with the help of the IPUMS CPS linkage ID, we are able to connect those different monthly files for the same individual. So you're basically tracking the same individual across time, across several months. And then also with the help of the same linkage ID, we are also able to link those monthly observations with their annual social economic supplement. So you have much more information, much more in-depth information in the annual supplement. And I'm going to show that with a figure here. I think this better illustrate what the CPS, the rotation principle means and how that actually map out on the samples here. So as you can see on the left-hand side, the 4 orange cells here actually represents samples in, the individuals in sample. So they are asked question for 4 months, the first 4 months in year 1. And then after that, the 8 months afterward, they would not be in sample. They would just not be in follow-up at the time. And after those 4 plus 8, 1 year, in year 2, there would be another 4 months in samples again, illustrated by the 4 orange cells here. So that's the 4-8 for the science. I think you have here more or less about it, about the CPS. And what is unique about the IPUMS linkage here is you will be able to see like the arrow down here linking the year 1 observation. I call it year 1, but it's not quite the start of the year. Year 1 observation with the year 2, and that allows you to follow the same individual. If we take a step further, you will see how the variables are actually mapped out. So our exposure measure utilize the raw observation of the weekly work hours. So the work hours all come from year 1's observation. It's repeated several times because it comes from the monthly basic. And our outcome data come from the self-rated health collected both in year 1 and year 2, but they are only measured twice because that come from the annual supplement. So that's how the data look like. And having understanding the timing of those different measures, the next step is try to distinguish what the survey directly observed from what we constructed later. So I think I have talked a lot about the raw data here. They are the self-rated health measured twice, and then weekly hours measured several times in year 1. They are actually measured in year 2 also, but we are not going to utilize them here. And several covariates, they all come from the year 1 baseline. And about our constructed measures, we constructed 2 different outcomes. They are both about health transition and also one exposure measure. So the health transition, named it here, is quite simple. Like the idea is try to compare year 2 with year 1. So to see whether the health is improved, being stable or deteriorated in year 2 compared to the year 1 baseline. And then the expanded outcome here is to adopt the same transition idea, but to add a 4th outcome state. We name it as the health-related work limitation. This is a new terminology here. And we just use it to describe working under specifically health reasons, like several limitations, such as working part-time, being absent from jobs, or exiting the labor market explicitly due to health, illness, or injury reason. Those are self-reported, and those come from several variables in the IPUMS harmonized CPS data set. And finally, the exposure variable, we follow other scholars' methodology, especially the Juliet Tice work hour volatility index. You can simply understand it as a standard deviation of the work hours across time. So we measure for the same person, how does the hour fluctuate from one month to another, basically. And about the analytical strategy, I will try to keep it brief here. But if you're interested in knowing more about the actual variables, I'm happy to answer that in the Q&A. So we start from the baseline specification using the work hour volatility I mentioned and try to predict how much that can associate with the health outcomes. And our expanded specification just expand both the sample and the outcome to follow workers who they might quit the labor market already, or they work part-time, or they etc., as we mentioned before, due to health reasons. So we expand both the sample and the outcome to capture those differences. And that's why we call it the selection-aware design or specification. And both models utilize the multinomial transition model to predict the health transition using the stable health as the reference categories here. And let's look at the results. So this table here is a partial table. It presents the regression outcomes for our baseline specification. The upper panel describe do the prediction on health deterioration versus being stable health, and the lower panel shows the health improvement versus being stable health. And you can see from the lower panel, there is nothing really going on there. All of the independent variable, both the main coefficients and the intervention coefficients are not significant. But for the upper panels, see from the two mouse columns, you can see that the volatility actually predicts the self-rated health deterioration among men, and adding the interaction with the weekly work hour actually make that story more nuanced. Because it involved the interaction, so I'm going to show the predicted probability figure. I think that better illustrate the potential association here. So again, the predicted probability figures here confirm a gender differentiated pattern, because for females, as we saw already, all the coefficients are not significant, as evident in the extremely wide confidence intervals here. But for the left-hand side, you can see the sharpest increase or changes in among all three different outcome states. The sharpest increase actually come from, come from the deteriorated health figures plot here, illustrated by the red plot here. So if you rise from volatility equals to 0, meaning no change of weekly work hour at all for the baseline, all different months in the baseline, the predicted probability of deteriorated health is only 28%, but if you goes up to volatility equals to 1.5, that's far more than the 99th percentile in our sample already, then the predicted probability would become 38%, so it's a 10% of increase, and that's huge for 1 year transition here. And if we slightly expand our samples and also our outcomes to include the health-related work limitation, as I said before, those are working part-time or exiting the labor market due to health reasons specifically, then adding the addition would be the fourth line here at the bottom, both at the bottom for males and females. And for the male story, it doesn't change much. So the most of the story going on are still the three plots above. But for female, it actually changed the story a lot. The scale might not appear huge here, but the relative magnitude are actually huge, because starting from volatility equals to 0, the predicted probability of health-related work limitation is only 2.5%. And then if you go up to volatility equals to 1.5, then 1 year later, the probability would become 7.7 already. And just like the show, I think the slide here shows the comparison between volatility equal to 0 and 1, and it shows that already that change, the volatility change already doubled this predicted probability here. So just to summarize the result here very quickly, work hour instability or volatility is a meaningful dimension of the occupational health risk, and we showed like within 1 year, the association was already quite strong here. And also second, gender shape how those health costs become visible, and there are two types of association here, different between men and women. And then third, the selection-aware sample and outcome construction construction really matters, and we are not arguing like the outcome construction is definitive, and there are more room to improve how you define the expanded sample and outcome, but just to give you an illustrative idea, and we hope there would be more future work on the similar dimension. So that's all for my presentation, and thank you so much for listening.
All right, so hello everyone. My name is Zhang, and I'm currently a doctoral candidate in sociology at UNC Chapel Hill. So I'm very excited to be here and then share with you all my ongoing work titled Life Course Trajectories of Depressive Symptomology in the United States, Longitudinal Integrative Data Analysis of Large-Scale Population-Based Cohort Studies. So this is part of my dissertation research that aims to contribute to the scholarship on social stratification of aging and mental health. So through the creation of a novel data infrastructure that link multiple longitudinal cohort panels, I hope that it will help us better understand or address questions related to the life course processes that would otherwise be challenging to answer with just one single data set. And also, I'd like to note at the very beginning that the results I'm presenting today are still very preliminary. And so, I welcome any comments, questions, feedback from y'all, and those will be super helpful as I continue to work on this project. All right, so some background on the substantive focus of the study. So depression is a major public health concern in the United States. So statistics suggest that there's a high lifetime prevalence of depression. So about 1 in 5 adults report ever experiencing major depressive disorder in their lifetime. And depression often begins, early in life with onset in adolescence. And so increases in depressive symptoms, early in life may well persist into adulthood. And previous studies have also, documented the deleterious health impact of depressive symptoms. So, for example, depressive a symptom is a risk factor for later life cardiovascular disease, cognitive decline and dementia, and also all-cause mortality. And secondly, research has shown that the development of depressive symptoms is dynamic across the life course. So studies have looked at different life stages, although evidence varies in the direction and also like pattern of change with age, but collectively findings indicate a potentially U-shaped nonlinear age pattern where the symptoms tend to be high in youth and then decrease in middle age and then increase again in later life. And additionally, depressive symptoms are not equally distributed across population subgroups. So women, minoritized racial groups, and individuals with lower SES tend to report experiencing more depressive symptoms. And when it comes to measurement, so numerous instruments have been developed, as scoring tools for depression in the community-based samples. So here I list 3 commonly used scales, and my study focused particularly on the CSD, given its wide availability in those large population surveys. Okay, so despite this great body of work, critical gaps remain. So first of all, no existing research, has characterized the age-related changes in depressive symptoms across the full lifespan. So key challenges include, inadequate data and research design to cover extensive life stages. So most analyses are limited to segments of the life course. So the fundamental data limitation here is simply that no single longitudinal or national representative studies that have followed individuals from birth to death. Okay, and the second challenge concerns measurement. So measurement equivalence or measurement invariance, I will use it interchangeably, has not been fully established. So it remains unclear whether the depression scales we use are valid and reliable for comparisons, for example, across age, across demographic groups, population surveys, and also over time. And additionally, the lack of attention to age period cohort confounding may yield biased estimates on the age effects on depression. And the second gap is related to the first one, but health social inequalities in depressive symptoms and how they unfold over the life course remains unclear. So to address these research gaps, my study has two general aims. So first of all is to characterize the age trajectories of depressive symptoms from adolescent to old age in the general US population. And secondly, to document demographic and social disparities in these trajectories. And I'm particularly interested in examining the trends across the 20th century birth cohorts, and also looking at the variations by gender, race and ethnicity, and SES. So my talk today focus on the first general aim on characterizing the age trajectories. And in order to do that, and also have a specific measurement aim here, which is to develop a commensurate measure of depressive symptoms across 5 large-scale population-based studies. So what are those? So the 5 studies I'm using here, include the National Longitudinal Study of Adolescent to Adult Health, or AdHealth, and it's health at UNC. And the second one, the National Longitudinal Study of Youth, 1979 cohort. I'm using the Young Adult Survey. And third one is American Changing Life Study, or ACL. And also National Survey of Midlife Development in the United States, MIDAS, and DHRS. So I employ an extensive life course research design by integrating data from these 5 studies to address the fundamental data limitation that I just mentioned. So as you can see from this figure, so these 5 studies collectively cover most of the human lifespan, from adolescence to old age, and specifically from age 11 to 90 years and older. And the birth cohort coverage is also extensive, so it ranging from individuals born in 1890 to those in the early 2000s. So these birth cohorts share, substantial age overlaps, and the sample size is large. I mean, like using, survey data. So it includes over 73,000 individuals followed over 39 years from 1986 to 2025. So you might wonder, right, like how would it be possible to combine these studies into one analytic sample? So I draw on a novel data linkage approach, which is originated in psychometrics called the Integrative Data Analysis, or IDA, which is a methodology framework for conducting pooled analysis of raw data from multiple studies. So there are several distinct advantages of IDA for longitudinal research. It enhanced the test of life course hypotheses over far more extended developmental and historical periods, and it has increased statistical power and also sample heterogeneity. For example, it has a greater representation of diverse populations. And it is, it effectively or efficiently use the existing measures that's already collected in those studies, and it can also directly model between study heterogeneity for valid population inferences. So despite these, advantages, there's one fundamental challenge in IDEA applications. It concerns the development of commensurate measures of exposures and outcomes across independent studies. And oftentimes, it's not uncommon during data harmonization that we find, the items differ between studies. It could be due to how questions are asked, what response options are available, or like which assessment are used across studies. So here is a small example. So suppose that we have a CSC item, felt depressed, that we found, available in AdHealth, ACL, and HRS, and we want to harmonize it across the studies. So it sounds like a simple task, right? But if you look, closely at the question, so AdHealth and ACL use the original, question in the CSC by asking respondents, how often during the past week that they felt depressed. However, the HRS, it slightly, tweaks the question by asking, whether the respondent think they felt depressed much of the time during past week. So how would you, harmonize the measures? So one option here is to harmonize response in AdHealth and ACL to be consistent with the coding scheme in the HRS, given, HRS has the fewest number of response options. So here, responses in blue are coded as no, and responses in red are coded as yes. Well, this might, seems to be like a face valid approach to get identical scoring, but the harmonized variable, may function differently across the studies because, if you think of, the threshold for people to answer yes, in HRS, it might not be, might not equal to that in the other two studies. So to address this issue, I used the moderated nonlinear factor analysis, or MNLFA, which is a general and also flexible model for assessing measurement invariance and differential item functioning. Here is a stylized depiction of a unidimensional MNLFA model. So one key advantage of this model is that it allows for the moderation effects of observed variables, either continuous or binary or like categorical, the moderating effect on any model parameters. For example, here, the arrows, pointing from X, the observed covariate X can modify the factor mean, factor variance, item intercept, and item factor loading. So applying MNLFA in the context of longitudinal IDA, we'll be able to obtain person and age-specific scale scores in the pooled data set. And these scores account for potential latent variable and item differences due to the known individual characteristics, for example, age, sex, race, and study membership. Okay. So to create the scale scores of depressive symptoms, I followed the principal procedure, which includes 6 main steps, essentially here. So first is a graphical inspection of the items we're going to use, or the universe of the item we're going to use for the analyses. And then the second step is to do dimensionality testing through exploratory factor analyses. And given the assumption of the EFA models that respondents need to be independent. So here we need to draw a calibration sample from the pooled longitudinal data set, and we'll talk about that in a second. And then we need to establish a unidimensional factor and then test for impact and diff. And then we will be able to compute the scale score for the pooled longitudinal sample, and lastly do quality evaluation of the scores. All right, so for the interest of time, I skipped the first step. And this table shows the baseline sample characteristics of the pooled dataset, unweighted descriptives. So to draw a calibration sample from this pooled dataset, I randomly selected one record per person with the number of individuals capped at 5,000 in each study for computing purposes at this stage, and also try to avoid the huge impact of AdHealth and HRS on the results given their relatively larger sample size. And the demographic characteristics shown here, for the pool sample also hold for the calibration sample, except for age. So steps 3 and 4 are conducted using the calibration sample. Okay. So after fitting the EFA models, I identify here a depressive affect factor indicated by 7 items that captures the negative affect and somatic symptoms of depression. So the factor loadings shown here on the right column indicate that the items differ in their relatedness to the underlying factor, but all contributed significantly to defining the factor. And the model fit indices shown here show that the model fits the data well. And next, I fit MNLFA models to the pooled calibration sample to test for differences in factor means, variance, and item parameters as a function of continuous age, both linear and quadratic, sex, and study membership. And the current analyses only include the main effects of these covariates. So this table shows the estimates from the MNLFA model testing covariate effect on factor mean and variance. Okay, so we see that all of the main effects are significant for the factor mean, whereas for the factor variance, H and H squared show significant moderation effect. All right, for the assessment of differential item functioning, I know this is a busy slide, but the key is that, the 6 out of 7 items, which, are indicators of the factor, display diff, meaning that there are significant covariance effects on either the intercept or loadings or both. So how to interpret the estimates? So if I look at for example, item 2, felt depressed. So we see that, so I use HRS as a reference group. So here, ACL respondents, compared to the HRS respondents, tend to endorse the depressed item at lower levels of depression or depressive affect, to be more accurate. And then for item 4, the estimate of age indicate that young respondents endorse the item sleep was restless, at higher levels of depressive affect than the older respondents. As for the factor loadings, so here's an example. I'll do this quickly. So if we hold the depressive affect, factor level constant, so we see that NLSY respondents are less likely to endorse this item, whereas for females, they're more likely to endorse the item. So this means that for example, for females, the effort was everything I did was an effort. This item is indicative of a relatively low level of depressive affect compared to the male respondents. So now that we have the estimates from the MNLFA model built using the pooled calibration sample, we can then compute scale scores for the pooled longitudinal sample. So this is just a preliminary result. So the figure plots the scores across age and then stratified by study membership. So the box plots here reflect the mean changes in depressive affect as people age, and it's we see it generally follow a nonlinear age curve, and we also see that there are substantial individual variability both within and across age. And this figure further plots the change in the mean depressive affect score across age and stratified by sex. So, the score shows a roughly parallel mean of depressive affect between males and female with a slight convergence in later life. But across all ages, female exhibit, a higher score, which is consistent with the literature. So I want to just note that these are the raw score. I haven't done any formal model to estimate the age pattern. All right. So in summary, I hope that through this preliminary analyses, I hope to demonstrate that longitudinal IDA is a novel data linkage approach to examine life course processes over extensive developmental periods. So the current study integrate data from 5 national cohort studies that collectively cover most of the lifespan from adolescence to late adulthood. So for IDA applications, harmonizing diverse measures across independent studies is very critical and can also be challenging. So the current application, pays particular attention to the measurement issue and try to, develop the commensurate measures, across studies. So here I use the MLFA model to derive scores for the pooled analyses, given its advantage of, accounting for study heterogeneity explicitly. But I also want to, mention that the choice of data harmonization, either be logical harmonization, for example, we do standardization across studies, or analytic harmonization, as what I'm showing here using psychometric models. Those decisions should be based on specific empirical context, and there's I wouldn't argue for which approach is better, but there's something to think about. So for future directions, I plan to include more interaction terms between, the covariates that are used in the current model, and then add in more covariates, for example, race variable is really critical for developing those commensurate measures. And then I'll evaluate the quality of scale scores by either drawing more calibration samples or doing simulations to assess how good those scores are. And then lastly, I'm gonna model the age trajectories of depressive symptoms and then test for the social disparity theory. All right, that's it. I look forward to the discussion.